Hey guys, welcome back to the show today and buckle up here because I have a lot of information to get to you today. And today's topic is going to be on why does my knee feel pressure when I bend down? And this is what you would consider an easy question to answer, right? Well, guys, we have a lot of information to get through today to help you better understand that feeling of knee pressure when you bend down. Now, number one is the question. Through the decades of your life, your knees can send signals that most of us really don't understand. We have been taught to call these things, these signals, these symptoms, whatever you want to call that. We've been taught to call these pain, but pain is not always the correct term for these signals. Now, pressure in the knee is alarming enough to cause us to stop bending when it happens. So in this episode, I want to break down the knee signals, the symptoms that you feel in various stages of life through each decade to introduce a different position for what is happening in your knee, and when you're feeling knee pressure, tightness, soreness, stiffness, or even pain. And I'm going to tell you what I see happening consistently in my studio, what the research supports, where the research is not available at this time. And I'm going to introduce to you three real people, and I'm going to tell you about a conversation one of these three people had with their local surgeon. And again, this is going to be a long one, so you may have to stop and come back to this. So here's what I see in my studio. I see people from all walks of life in every decade of their lives. And they are describing knee symptoms or signals that all get categorized as knee pain. And this is mainly due to the lack of understanding and education in the area of health of the joints and muscles, and a lack of awareness of what is pain and what is not pain. So it's all just called pain. But before the pain, people typically have other signals or symptoms that tell them they're losing the motion that is deep inside the joint. Now, we do have downstream diagnostics for when we do have pain. We also have pain management models, but we don't have testing for pressure in the knee when you bend down. And this episode is going to answer that. So the question most people ask is, when you have pressure in the knees and not pain, what is the pressure telling you, and should you be concerned about it? So I want to break this down, this pressure that you're feeling in your knee when you bend down, and I want to walk through what this signal is telling you and what you need to know about the risk of waiting until it becomes pain. Now, here's why we ignore this pressure in our knee when we bend down. We are accustomed to thinking our movement health is good until we have pain. And pain is not the measure that we should be using to quantify how healthy our movement is. Pain is typically a late signal, and by the time you experience pain, you either have a diagnosable condition or you will soon have a diagnosable condition. So waiting for pain may not be the best practice for those people who want to ensure they can move that last half of your life. Now that is what it's all about, right? Being able to move and do the things that you want to do every day of your life. Like in your 50s, your 60s, your 70s, and your 80s, all of us want the ability, the capacity, and the function to move in those later years. And right now we know there is a large gap. So let's talk about this and the knee. Knee pressure at a deep bend is not a continuous symptom or signal. It happens only when you go into a deep bend. For many of this is not a position that we get into often. So this pressure is typically ignored because it doesn't interfere with our ability to function every day. And I want to break that down, okay? Because there is a good reason for that, and that is actually measurable. Now, let's dig into some research here. Researchers put some sensors on the knees of 20 healthy older adults. The average age of these adults was 67, and the researchers had them go through a circuit of ordinary activities. Now, they measure how much knee bend each of these activities actually require. So walking on flat surfaces was measured, walking on a slope surface was measured, ascending and descending stairs, rising up from a chair and sitting in a chair in different various heights. And then the last thing was getting into a bathtub. Now, what they found is that walking on flat surfaces or slope surfaces required less than 90 degrees of a knee bend. Now, I want you to hang on here, okay? This information, I'm going to pull this all together, okay? Ascending and descending stairs and rising from sitting in a chair, whether that is a low chair or a higher chair, it requires about 90 to 120 degrees of knee bend for that action to happen. And then when you get into a bathtub, it required about 135 degrees of knee bend. Getting down to the floor was not on that list. They actually didn't measure that. Now, a healthy bends to 135 degrees approximately. So, and that depends on soft tissue, okay, girth. So walking uses less than 2/3 of your available knee bend. And walking is what most of us do every day. You could actually lose a large part of your available bend, and you're not going to really notice it if all you do is walk. You would notice the loss if you're getting down to the floor daily and up from the floor, because that is the only thing in your ordinary day that requires full knee bending to achieve it safely without a symptom or a feeling. In my opinion, only symptoms are a medical term. And I prefer for people to be able to describe what they are feeling with movement, because not all feelings are symptoms. And guys, that is just my point of view. It's also not aging. And aging is what most people use to describe the pressure during a deep bend. And since most of us don't bend that much, it sounds logical, right? So let me tell you what the research says. Research measured hip and knee active range of motion across different age groups. The difference between the youngest and the oldest groups were generally 3 to 5 degrees of range of motion. Now, hip extension was the one exception where the difference was larger. And in this test, they established, again, with the possible exception of hip extension, at least to age 74 years, any substantial loss of joint mobility should be viewed as abnormal and not attributable to aging, and therefore it should be treated much as it would in a younger individual. Now that study is cross-sectional, which means it compared different people at different ages rather than following the same person through a point in time. So it's not a promise that nothing changes, is though a statement that a substantial loss in movement is not explained by age on its own. So the question becomes, what does the pressure mean, and should you be concerned? And before I tell you whether you should be concerned, I have to tell you what the pressure actually is. So let's dive a little bit deeper into the mechanics of the knee itself. So here's what's actually happening in the knee. Your knee is actually the largest joint in your body, and that's because of the size of the condyles. It's also not a hinge joint. Many people don't know that. Everyone calls it a hinge joint, okay? And the anatomy texts do not. They call it a modified hinge joint. And that word modified is what better describes the complexity of the knee joint. Now, your knee bends and it straightens like a hinge. It also rotates, and the rotation is built into the shape of the bone. And that rotation is what I want to introduce to you today. Look at the bottom of your thigh bone. It ends in two rounded knuckles called condyles, one on the inside of the knee and one on the outside of the knee. And those two knuckles sit on the top of your shin bone. Now, these two bones are not the same size. The shin bone and on that condyle on each side, they're not the same size, okay? The articular surface of the one on the inside of the knee is longer than the one on the outside of the knee. And that difference is why your knee is able to lock and unlock. So let's talk about the last 20 degrees of straightening of the knee. So if you're standing tall, you're locking out your knees, you're straightening your leg. Those two condyles, those knuckles, they actually roll and glide backwards across the top of the shin bone. Now, the one on the outside, the shorter one, actually doesn't have as much space than the one on the inside does, okay? And this is what allows that rotation to occur, the lockout mechanism. Now, during the last 20 degrees of extension, the tibia rotates externally about 15 degrees relative to the femur, and that is called the screw-home mechanism. Some people call it the locking mechanism, and it is not something you do or that you have any control over. It's not a muscle contraction. It happens because the shape of the bones, and it's involuntary to your control. Now let's break down what happens with that rotation, or why is this rotation necessary. So in standing, two things happen. The joint moves into what is called a closed pack position. The surfaces are maximally congruent and the two bones are seated into each other, and that provides a stability. Now, in this straight position, the ligaments are tight, and when the tibia is externally rotated relative to the femur, the cruciate ligaments wind and they become taut, and that's what gives you your stability. Now, this occurs involuntary to your control, and this is what happens when you stand with a locked knee. This position is built to be stable. It resists bending, and this is why you can stand around for a long time with your legs straight without any muscular effort at all, and that's the feature your knee was built for. Now, if the rotation locks the knee, then the rotation has to reverse before you can bend the knee, and you can't bend out of a locked position. Your joints and bones have to unlock first, okay? So I want you to stay with me here. I know this is getting a little bit complicated, but you're going to want to understand this lock and unlock mechanism. Now, there is a smaller triangular muscle deep behind your knee, and it's called the popliteus. And in the anatomy text, it is called the key that unlocks the knee. And its job is to reverse the screw home rotation so that flexion can begin, or so that you can bend your knee. And when your heel is off the floor, it does that by rotating the tibia inward. And when your foot is planted on the floor flat, the shin cannot rotate freely because it's fixed to the ground through the foot. So the unlock happens when you go to roll off your toe. The femur actually rotates outward on the fixed tibia. And then the hamstrings are going to take over to do the actual bending of the knee. So the sequence for bending a straight leg is your knee needs the capacity to unlock first, that screw home mechanism, then your knee can bend. And your knee needs this mechanism to keep the joint and muscles healthy. So let's ask this question. What happens if the knee cannot fully unlock itself when you go to bend? And think about who would notice this. You wouldn't notice it walking, because walking doesn't require 90 degrees, and it barely requires the joint to leave that comfortable middle range. You would not notice it when you go to sit and stand from a chair, because the chair is it falls in between that range. And then you wouldn't notice it when you're just walking up and down stairs, okay? You would, however, notice it when you're going onto the floor, because that movement requires full knee flexion to its end range. And if you bend down on one leg down to the floor and your knee was no longer unlocking during the bend, this happens when you lose that knee unlock mechanism. And that is what you feel. That's when you're going to feel that pressure that you described when going down to the floor. But guys, that mechanism that is lost is also associated with motions above the knee and motions below the knee. So I do want to mention that most of the research available is on squat movement of the knee, okay? I do have some good research to kind of dig into here today, which is cool. But because the movement people most describe in the research is squat-based research. And what I'm looking at is someone on a single leg going down to the floor, lowering onto one knee and dropping down to reach something or picking something up. Those are asymmetrical movements. They only require one limb, and they usually load one leg more than the other leg. And they actually have a rotation to them, okay, which the squat really doesn't. It's more of a hinge. Most of the research on deep knee bending is used for squat research. And that's more of a symmetrical. You have both of the legs that are planted, and that research tells us that something different. What my clients are saying when you're asking what this pressure is not the same as that research. So I'm not going to use that squat research for this. Now, here's what I test in the knees at my studio. I find that the tibia sits in external rotation in the population that's lost this screw home mechanism. External rotation is the locked position, and that's the knee's position in a fully locked out straight position. So the tibia is sitting there and the knee is sitting in its locked configuration when it should be free to rotate into a locked and unlocked position. And I find the knee restricted in its accessory motion, which is how it can rotate. Again, this rotation is out of your voluntary control. So these are small movements between the joint surfaces that you can't produce on your own when they are locked down. And above the knee and below the knee, I find the same thing when I test. I find hips that are restricted into rotation and restricted in accessory motion. And when I find a hip that is restricting joint motion, I typically also find restriction below it. So the midfoot, the rear foot, the subtalar joint, the ankle, the great toe, some of them or all of them may or may not be restricted. And guys, that isn't a research finding. That is what I find when I test. And I find it often enough that when I see someone with knee pressure, then I know I go up above the chain and below the chain. Here's my explanation. I go back to the mechanics. The unlock in a closed chain requires the femur to rotate outward on the tibia. And that rotation has to come from somewhere. And the joint, if it's not going to come from the knee, then the joint above it is the hip. And when the hip is restricted, the femur can't move freely, okay? And remember what the unlock actually is. It is a relative rotation between those two bones. And if the femur can't turn, the rotation between them doesn't happen and the tibia sort of stays locked up where it is, okay? So I'm not going to tell you exactly which direction of the hip motion matters here because the research on that is genuinely divided and it appears to depend on where the feet are pointing or positioned. And what I can tell you is that the hip that has lost rotation and lost accessory motion is a femur that cannot do its job, and then the knee sits directly below that. Now, if we look below the knee, the foot and the ankle are what allow the shin to find the ground and adapt to it. So when those are both restricted, the shin has fewer options to rotate. So there is one piece of research which is worth showing you here. There was a research study that looked at 30 healthy people with no history of injury, and they actually restricted their ankle motion during a squat. And when they did, the knee bent less, okay? It sort of traveled, the knees traveled inward more, and then the quadriceps muscles did less work, and then the body compensated, and I think the calf did more work. Now, they created that restriction artificially with a wedge, so it's not the same as a person who has had a restriction for years in the knee, the foot, the ankle, or the hip. But it does tell us that when the ankle cannot move and it's restricted, the knee does something different, okay? So we can associate it with that. So the femur cannot fully do its part of the unlock. The tibia stays parked in that external rotation position, which is that locked position. So the knee does not fully come out of its locked position. And when the person asks for their body to move and use up that entire 130-degree range of motion, that's where they meet that resistance, and that's the pressure that you feel. Now, here's what is established and what is mine. I want to be very clear about the status of what I just told you. The anatomy of all of this is very established. The condyle shapes, the screw home rotation, the 15 degrees over the last 20 degrees of extension, the ligament tightening, the requirement to unlock before bending, the popliteus as the key of that, which is that muscle behind the knee, that triangular muscle. All of that is taught in every kinesiology program in the country, and it's not controversial, okay? What I want to be clear about is that this right here is not just a physical therapy idea, okay? There are also 3 different professions that assess restriction at the knee, and they all have arrived at the same place from different directions, and they each call it something very different. So I'm going to go over that just briefly here. Physical therapy calls restriction is a loss of accessory motion or a loss of joint play or hypomobility. The osteopathic medicine calls it somatic dysfunction. And there is an osteopathic teaching material on the knee that uses the rotation position of the tibia as a diagnostic test, and that describes assessing for what they call a restrictive barrier. Now, chiropractic calls it a subluxation or a fixation or a joint dysfunction. And there is an entire certification around that. And I think it's a 7 seminar series, 105 hours, producing what they call certified chiropractic extremity practitioners. And there are more than 1,500 of those practitioners worldwide, and their teaching material has chapters on hip fixations, knee fixations, tibial subluxations, ankle subluxations, foot and toe subluxations. So guys, these are three professions, three vocabularies with the same idea. They all believe that joints get restricted, okay? And that restriction matters, and that restriction can be in various joints in the body, okay? So the chiropractic council writes that when an extremity restriction is left unaddressed, the body overcompensates and problems show up in other joints. So when I tell you that a restricted hip and a restricted foot leave the knee doing something it was not built to do, I'm not saying something novel. I'm saying something three professions are taught for decades. So let me tell you where I actually sit on this, okay? People come to me with symptoms. Of course they do. That is how most people find any of us. Most of these people come in after they've exhausted physical therapy, osteopathic, they've seen doctors, they've had medications, they may have had injections, they see chiropractic regularly, they see massage. So most of my people come to me because they've lost all hope. Now, the difference is in what happens next. I do not manage pain. That's not my lane, and I don't even want to do that. I don't change symptoms, anything like that. What I do is look precisely at how the joint is moving and how that relates to whether the muscles that support that joint are switching on the way that they're supposed to switch on. Because those two things actually work together. A joint that is not moving well sits above a muscular system that is not activating well. It's in a holding position. And I have never found one without the other. And here's what I could not find anywhere. Let me say the fair thing first, because this is important, okay? All three of those professions can restore motion. And when a physical therapist mobilizes a joint, that is restoring accessory motion. When a chiropractor adjusts the joint, that's restoring motion. When an osteopathic physician works a restrictive barrier, that is restoring motion. I'm not going to stand here and tell you they cannot do it, because they can. What I see is different from how the motion is restored and whether that motion is kept throughout your lifespan. So from what I see, a mobilization does not give the joint back its full accessory motion. And from what I see, what it does give does not stay. It doesn't last. And it doesn't last because the model itself is not built to find out through a whole lifespan, because the model stops when pain is gone, okay? Not because anybody decided that they needed to stop, okay? Therapists don't want this, but because people stop coming when pain is gone. And once pain is gone, then they start getting into this cycle of symptom chasing that they provide treatments for, and that care becomes reactive. So you go back when it hurts again, okay? There is also a question of scope. A physical therapist works the joint that is driving the complaint. Some of them are going to work above and below that. It depends on what model you are seen in. There's a large variety of physical therapists out there, from private pay to insurance-based clinics to big systems. So most of the time, because of insurance, you're going to get worked on at the knee and possibly some stretching and some strengthening above and below, okay? But not anybody or not everybody is working on every joint in the body and the entire muscular system, as well as all the 5 drivers of healthy movement, and then keeping it going so that a person doesn't lose their mobility in the second half of life. And that's the difference that I see. Nobody is also testing any of this stuff upstream to find restrictions. All of that assessment across all 3 professions happens after somebody arrives with a complaint. Not one of those professions goes looking before there's a symptom, and not one of them set up to restore the lost motion and then preserve it for healthy movement over a life. And that's what I keep coming back to. The motion gets restored, the symptom is resolved, the person gets discharged, and nobody is watching that joint in 1 year, 2 years, 3 years, 5 years. Restoring the motion is the end of the story. It's not the beginning of one. So let me tell you plainly how I am different. A physical therapist restores motion when something is wrong. Chiropractor does the same thing, except they also do a little upstream preventative work. They're trying to get people in earlier. An osteopathic physician restores motion when something is wrong, and then you are discharged because the thing that was wrong gets better. I test the motion before or during when something is wrong. I restore it and I keep it healthy for the rest of your life. That's the difference. It's a different job. They fix the joint that is hurting. I keep every joint healthy so it doesn't become the one that hurts. And you do not have to choose. See your physical therapist, see your chiropractor, see your physician, then come to me for the part that none of them are doing, which is keeping your whole movement system healthy so you are less likely to end up back in their office. And when researchers have tested whether two trained clinicians examining the same joint arrive at the same finding, agreement has been poor across every one of our professions. So the idea is everywhere. The measurement is not. Nobody is using it upstream and nobody is looking at it over time and using it as a measurement stool or a baseline measure. And that's the biggest gap that I see. There's also research showing that rotation at the knee is reduced in people with knee osteoarthritis, and that screw home mechanism itself is altered in those knees. Now, one study found the reduction in rotation showed up in early stage rather than late stages, but those are cross-sectional studies in people who already had osteoarthritis. They already have a disease, so they cannot tell us what came first, okay? And nobody has taken people who describe pressure in a deep knee bend, measure where their tibia is sitting, or measure where their hip and foot are doing and connected all of those. Now, that study doesn't exist. I've looked for it. So that is the study that I feel like needs to happen, because that is where my working explanation shows that we need to go. And I think that would be a cool study. Now, what happens if you don't address that knee pressure? I mean, you can't feel it when you sit. You can't feel it when you're walking. During your day, it really doesn't bother you. So really, is it even important that you do anything about it? And here's what I can't tell you. Nobody has run the study where you take people with this restriction, okay, and you address it in half of them, you leave the other half alone, you see what happens over the next 20 years. So I'm not going to tell you that testing your joint mobility is going to prevent a knee replacement for you. Nobody knows that. Anyone who tells you that is not going on past the evidence. They're not telling you what is going past the evidence. What I can tell you is what a sequence looks like. And this is the cool part. Now, guys, this is sort of a predictable movement decline pattern, because I've seen it step by step for the past 10 years or so. So let's go back to that study on how much knee bend ordinary activities require, okay? So when we're walking on flat surfaces or sloped surfaces, you don't need but 90 degrees. You need under 90 degrees of knee bending. When you're walking up and down chairs, you need about 90 to 120 degrees. And then if you're stepping into a higher surface, say a bathtub, you need about 135. Now, think about what that means as you lose the available bending in your knees. The deepest goes first. So getting down to the floor and kneeling or getting into the bathtub, that's the first thing that you're going to feel that pressure. If you don't address it, then you're going to feel that pressure in a low chair. Then you're going to feel it in the stairs later. Later, you're going to feel it just when you're sitting in a standard height chair. And walking is going to be the last, because it doesn't require a whole lot of knee bend to happen anyways. Now, activities that you do on a daily basis don't fail on a daily basis, because you're going to be losing little traces of movement and because you don't get down to the floor very often, that movement's not very important to you, which means by the time somebody notices this walking, then enormous amount of movement is already gone. And that's not a prediction, guys. That is what the numbers describe. Your available bend and the demand of your day are two separate things, and the gap between them closes that gap. And here's what people that do have that sensation typically do, okay? they actually stop going into that deep bend. And I'm not going to blame anybody for that. It's a sensible response. Someone feels pressure, in that one position, and it is a position you don't do very often. So it's smart enough to just find another way to get something off the floor without going into that position. But I do want you to notice what just happened. When you have that pressure and you stop going into those positions, the range that produced the sensation is now a range that you're not going into. So you're going to end up losing that range, okay? And I have to be honest about evidence for what happens next. There is a body of research on what happens to a joint that stops moving. This research study is pretty cool. They immobilized knees in an animal model and followed the tissue over 16 weeks in the knee. Contracture developed early and it progressed. So when they released the back of the joint capsule, the immobilized knees gained significantly more extension than the controls did, which told them the capsule itself was the restriction. Now, other groups have gone as far as mapping which genes change in the capsule and when. So these are pretty cool studies. But guys, this was in rats and it was under rigid immobilization. That is an extreme end of not moving. They totally didn't allow the knee to move. And it was not a person who was still actually moving around and avoiding the floor. So we can't create that study to be equal. But it does tell us the direction that the tissue progresses. It doesn't tell us the rate in humans, but the direction that it goes in is what I want you to understand here. So if you're walking and moving, you're not going to lose as much of that involuntary movement, that lockout mechanism. But if your ankle is restricted and you've lost some motion and you stay in that position over a long amount of time and you're not getting movement, there is research to show that the capsule just tightens and gets progressively tighter and tighter and tighter, and then the movement has to come from somewhere else, okay? Now here's another study. They followed about 148 people, and they were aged 35 to 54. And all of these guys, they already had chronic knee pain. All of them had normal knee x-rays at the beginning, even though they did have knee pain. 5 years later, they took the x-rays again. The people who could do fewer leg raises from a chair at the beginning were more likely to have osteoarthritis on their film 5 years later. Now the median was, I think, seven rises against 25 rises. So people could do 7 or they could do up to 25. Okay, so the people who could do less of them, of those rises, the bend, okay, actually were the ones who did develop osteoarthritis that was then shown 5 years later on an x-ray, okay? And they held that after accounting for age, sex, body weight, and pain, okay? So that was a pretty cool study. You can have somebody, just do it. I think it was a single leg chair test. And depending on how many single leg chair tests, sit to stand, that you could do, the people who did less ended up with osteoarthritis 5 years later on a scan when they had pain 5 years earlier, but the actual x-ray didn't see it. So it's really cool that everybody in that study already had pain. It doesn't tell us that function declines before symptoms. What it does tell us is that the film itself, that x-ray, in the beginning, there was no arthritis, and in the end, there was, okay? So I thought that study was pretty cool. And as I told you before, there was a study that said if you've got this pressure and in a 70-year-old and you don't have pain, then you can't blame that on getting older, okay? So if we can't blame it on aging, what is it? And should we be concerned? And here's my answer, okay? The sensation of that pressure tells you something has changed in your movement system. And that's all it's telling you. It's not telling you how much, where, how long it's been going on, if it's affected or inhibited muscles. those are testing questions, and I can't answer those questions for you, okay? And you're going to feel what you feel depending on things, but the feelings that you have are not necessarily always a symptom. They can't be measured on an x-ray or a scan. What I do want you to understand is that the thing that you are least likely to notice is you're not going to be getting down to the floor very, very often, or you're going to stop getting down to the floor because of the pressure. Not going to notice that you're losing range of motion in your knee because your body is going to tell you to not use that knee, okay? So I want you to see how this looks in 3 different people. And these are people that I have seen in my facility, in my studio. I'm going to start with a 30-year-old because I want you to see this path of a 30-year-old and then an older person in their 50s and then an older person in their 70s. So I've got 3 different people, and these aren't really a case study, okay? I just want you to see this path, this predictable movement decline path. Now, the first woman is in her mid-30s. She came to me completely asymptomatic. She had 0 pain, 0 symptoms, no pain with walking, no pain with stairs, no pain doing anything in her ordinary day life, except when she went down to the floor to play with her young child, she felt pressure in her knee. She had already explained it to herself. She told me that it was knee pain and that she was getting older. You see what I'm saying? She called it pain, but it was pressure. So let me take the easy explanations off the table one at a time. This girl is not overweight. She's not even close to being overweight. This is not a load problem the way most of the researchers look at load if you're heavy or overweight. She is in her mid-30s, and the research I gave you says that up to age 74, a substantial loss of joint mobility should be considered abnormal rather than attributed to aging. And she has no symptoms during regular movement at all, and there was no injury and no ongoing problem to point at. Then I tested her. Both of her hips were restricted in every plane of joint movement. This isn't just one direction, okay? Every plane on both sides, both her right hip and her left hip. Her forefoot, her midfoot, her rear foot, and her ankle, all restricted. She was asymptomatic, and she was wearing cute flat shoes with no cushion. And she told me that those are the types of shoes that she wears every day. She wears them in her tennis shoes, her flat sandals, whatever. She wears cute flat shoes. She really doesn't wear anything else. Now, I want you to think about what going down to the floor actually asks of your body. What has to move? Well, guys, it asks the ankle to travel forward over the knee. It asks the foot to adapt to the ground, and it asks the hip to bend, okay? Every one of those joints with her testing were restricted, and the knee is the joint sitting in the middle of all of that. Now, she was not feeling a knee problem. She was not feeling the one movement where she had to get down to the floor that bothered her. That didn't bother her at all because she had just modified it and started using the other knee to get down to the floor. So here's what happened in that session when I saw her. Her hip restrictions improved. She gained almost full end range accessory motion in most of the planes in both of her hips. It was pretty cool. She doesn't have any arthritis or anything like that, okay? So she gained that accessory motion at the knee. She gained the lockout mechanism. She gained the stability at the knee, the hip, the foot, and the ankle. And she walked out moving better than when she came in. She felt amazing, actually. And I wanted to tell you about her because she didn't sign on for care. Okay? And she didn't sign on for care because she works in the medical field. She knows she does not have pain. And in the medical system, she works inside of no pain means there's no reason to seek care because there's no testing. Okay? And she felt better. She thought, I've done what I'm supposed to do. I feel fine. What she doesn't know is that lockout mechanism and everything is going to stop because that is a silent process. And once it starts, you have to continuously work on it till it is stopped. And because so many other factors happen, she's got little kids and stuff. She's going to feel fine, okay? And probably that pressure isn't going to be there to give her a signal, okay? So I know this relief that she got in one session is not going to hold. One session is going to open the space. It doesn't keep it open. And it is involuntary, so the body will take that away. She's in her mid-30s with restriction in every plane of both the hips and restricted throughout both feet. And right now she has no reason to think about any of it for the next 30 years. Okay? That's not failure in her judgment. She applied the rule she was trained in, and the rule says, wait for pain. So we've got a lady in her late 50s, okay? So let's say mid-30s, late 50s, so another 20 years goes by, okay? And everybody is a little bit different, but I do see the same pattern in the people that I see in my facility. This lady did not come to me about her knee at all. She came about her right hip. It had locked up completely, and it wouldn't let her move. And that hip is better now. Her back is better, and now her left knee is tender, which is kind of funny. She's like, it's like this, my pains and things after 50 sort of move around all around my body. She goes, and this is how she describes it, okay? She was perplexed. Even though she called it pain, then she said, well, it was really not painful. She said the knee feels tender to touch, and that if she swipes her hand across it, it's tender. And then she said, what drives me crazy is I didn't do anything. I didn't hit my knee. I didn't fall down. I have not injured myself. I just woke up this morning and my knee is feeling weird, just like the hip did that day that it locked down. Then she told me she feels like she is compensating for that knee, but she can't figure out what she is supposed to do about it. She can feel her own body making adjustments. She doesn't understand it, and she doesn't have a name for it, okay? And she doesn't know what to do. So here's what her testing showed that day with her knee. Her right hip is still restricted, and it's now completely asymptomatic. Her left hip test restricted as well. Her right ankle is restricted. Her midfoot and rear foot on that right foot and her tarsals all restricted. Her knee itself is actually moving, which is cool. That lockout mechanism was still there. Now I want to point out something. The knee is tender on that one side, and the restricted ankle on the right foot on the opposite side are restricted, and the foot's restricted. Okay, so I don't have an explanation for that, and neither does the research, but the other thing shows that some of her muscles are inhibited and some of them are not doing their job, as well as some of her pathways to her brain, how her body communicates, aren't fully operational either. And that's what her feeling of compensation actually is. It wasn't all in her head. It is that her system where she is right now, some parts have come back online and some have not. And she leaves her session with no limp, and she tells me she feels in control of her knee. And this lady gets seen weekly because she's just trying to get and keep her joints and her muscles as mobile as possible. She wants to be able to do everything she wants to do in her life right now without having to be slowed down by pain. Now, my next person is a woman in her 70s, and this is a pretty cool story here, okay? She has arthritis in her toe and her feet, and very limited range of motion and very limited accessory motion, okay? She's actually lost most of her muscle to degenerative changes in her feet, and her left hip has been restricted for over 6 months now. And actually, she came to me 10 years ago with her back, so I would say she has been battling this hip restriction in her hip for over 10 years, okay? She comes to see me now twice a month. She trains with a personal trainer twice a week to maintain her strength and to build strength. Now, with that program, she was asymptomatic for about a year. She also has moved into a barefoot shoe. So this lady has made tremendous strides for being in her 70s. And she moved into the barefoot shoe because she reported that after she gained that strength, it actually took her knee pain completely away. And that worked for her. I'm not going to stand here and tell you it didn't work. So this is a woman in her mid-70s with real degenerative changes in her feet, and her hip is restricted on both sides and has been for 10 years. She has been trying to keep that unlocked through seeing me twice a month, and then she's training twice a week, seeing me twice a month. She's doing deep thermal laser for her arthritis in her hands and her feet. And that had been working for her for about a year, with no symptoms of pain. And then the knee pain came back. And in our next session, I worked her lower body and she walked out with a clear direction and no knee pain. Okay. I just want you to look at these facts here. Then, for no reason, she had to take a 3-week sabbatical from strength training. Okay. She came back and told me that the pain in her knee had gotten worse. So she went to her surgeon and he told her that she was bone on bone and that she should start preparing for a knee replacement. And I'm just thinking, what the heck? You know, after my session, she has zero pain. She walks without a limp. She's feeling good. So 3 weeks off, guys, didn't create her bone on bone. That structural change was already there, and it had probably been developing for years. And you develop these bone spurs, this arthritis, because of uneven loading. Okay, we do know that her hips were restricted, and that's going to cause it, and her ankles were restricted, and her ankles down to her toes were all degenerative. Okay, so that's going to cause an uneven loading in her knees every day. So every day she stands, she walks, whatever, she's going to have uneven loading, and that's what's going to produce more osteoarthritis. What I do not know, and nobody knows this, is whether those 3 weeks that she took off of strengthening changed anything at all, or whether it was timing, or whether it was coincidence. This is just one person, okay? I really don't have anything to compare this to. What I will say is what I can support. She had a system that was holding. Then several parts of that system stopped at once. She no longer trained and did her strength training. And the routine that structured her week, that's when kind of everything stopped, and then the knee actually started screaming pain. And when I saw her after that, her knee joint was restricted. She had lost that lockout mechanism. Both of her hips were restricted, both feet and both great toes, they're degenerative. Okay, so she had very little mobility in any of the joints of her feet and ankle. And she walked out of that session pain-free and feeling good. And she walked out headed to physical therapy to start preparing for a knee replacement, okay? And when I'm doing my testing, I didn't feel any arthritis. I mean, she had full available accessory motion when she left, which is really interesting. There's more to say about her and about what her surgeon told her. And I'm going to be coming back to this one at the end of the show, because I do want you to know that. But I want you to see what these 3 ladies, the 35-year-old, the mid to late 50s, and the 70-year-old, what those 3 ladies have in common. One woman, with no symptoms at all, except for when she went to bend down into a deep movement on that one side. One woman in her late 50s who called that knee pain and then said it wasn't painful, and she was just trying to figure out what the heck happened. And then one woman in her 70s with established structural change. She had osteoarthritis. All 3 had restricted hips. All 3 had restricted feet or ankles. Not one of them came to me talking about the hip or foot. 2 came in talking about the knee, and the 3rd one came talking about a hip, and then the knee kind of showed up later. Now here's what separates all of them, okay? And guys, it's not just their knees, okay? The woman in her 30s had restrictions, but she didn't have pain, she didn't have inhibition or anything else yet, okay? Her body was pretty much functioning good at this point. She had not gone through perimenopause, menopause, or postmenopause, okay? The woman in her late 50s has joint restrictions in her hip, her feet, her knees, her ankles, plus muscle inhibition, plus a system that is partly back online and partly not. And the woman in her 70s has all of that, plus established disease in the exact joints that are supposed to be protecting her knee. Now, these are not 3 different conditions, okay? That's one road, guys. This is one path with 3 people standing on it at different points. And the woman in her 30s, from what I'm seeing, she is on a predictable movement decline path right now, okay? So what I want to be clear about is there is a way to score this. We do know how to find restrictions. It's in the literature out there. You can test these restrictions on people who have pain. You can test these restrictions on people who have disease. You can test these restrictions on people who are asymptomatic, okay? What I am saying is that what I have found in my practice is that if we start testing and we give a score to show a person who feels fine that something is actually restricted and there is a process underneath, sort of an awareness instrument. And this is an important tool. It's something that we can use to our advantage to be able to show you, hey, are you on a path? Is there something you can do now in your 30s that may predict or be associated with decreased disease or decreased metabolic disability or decreased surgeries? We really don't have that answer right now, but it is pretty cool to see the people in my studio. They are not progressing on to surgeries, with the exception of this one lady who all of a sudden is going in for a surgery. And I'm going to talk about that more because I just want you to understand this process. I want you to see the predictable path here, a movement decline, but I also want you to understand what you're told in the medical system and what it means, okay? Here's what I don't know though, okay? I want to end, let me go through some other stuff here. I don't know whether the pressure people describe corresponds to anything measurable inside the joint. Nobody knows that. There has not been a study on that I'm aware of. And what I have given you today is kind of a set of findings that each stand on their own. And in my working explanation for how they fit together, that explanation is totally mine. It's not been tested. I'll tell you when that changes. I do not know how much of the restriction I find caused the sensation and how much of this is the result of the knee that has been moving differently for years. And I meet most people, most after they are already, in a problem where it's been locked out for a while, so they're symptomatic. Most of the symptoms that people come see me are just tightness, or they want answers. When we follow people forward from before a symptom and we measure it in the same way over years, I haven't seen that study be done, but I would like to see that study done. I do follow people for years in my facility, and that's my whole model, okay? My client in her 70s has worked with me for close to 10 years. She started with a different body part that was not her back. Not her knee. She started twice a week. She went down to monthly visits, and over that decade, her frequency has moved up and down based on whatever she was feeling in her body and what we were testing. When she was symptomatic or she was feeling something that was off, she would get on the table, we would measure, we would see a restriction, and then she would increase her frequency, and we would get her to a place where she felt like she could manage it and she could decrease her frequency. That is a pattern I have watched for 10 years in this one person, okay? And I've got 4 or 5 clients that I've seen for multiple years, many over 5 years. And here's what is different this time with this lady. When the symptoms came back for this lady, this time she did not increase her frequency, okay? And that doesn't mean anything. It just means that several things happened here, and I want you to hold on to all of that, okay? Because I'm gonna pull this to a close because I know this has been a long show. I want to be honest what that is and what it is not. It is not evidence, okay? This is one person, no comparison, and no way to separate what she did from everything else happening in a body in her 70s. And I'm not going to tell you that frequency is the reason that she's having surgery, okay? None of us know that. I want to be careful not to turn that into a story about frequency because a lot changed at one time for her. She stopped increasing her sessions. She stopped training. In between that 10-year period, she also aged 10 years, and she had inhibition in many of the muscles of her body. And she also had degenerative hands, wrist, fingers, toes, forefoot, and ankles, okay? So I want to dig into some more stuff here because I want to pull this together for you. I want to come back to my client, this one that are in her 70s, okay? Because there's something in her case that I really can't explain, and I'm going to say it plainly here. Three things are true at the same time, but they don't necessarily agree with each other, okay? Her surgeon took an image and he saw bone on bone, okay? And he is trained to see those things. She felt pain in her knee, okay? She knows her own body, and the pain was something that was just too much for her. And when I put my hands on her and on that joint, the lockout mechanism was there after I opened it up. She was able to lock that out and then unlock it, okay? She gained more accessory motion. She gained accessory motion in her knee, in her hip, and that's about it, because her foot, we can open up a little bit, but that's degenerative. And then she's lost about 80%, I think, of her great toe on both sides of her body, okay? What I do not know is how to reconcile all of those three things, okay? The imaging was there, okay? Her pain was real, and what I found was real, okay? What I can tell you is that each of us is actually measuring something different. The surgeon is going to measure the structure. The client is going to measure, how her knee felt. And I am going to measure the available motion and the inhibition. Three different things. There is no rule that says they have to move together. And for her, they didn't. Now, I've read enough to know that I am not the first person to run into this. Findings on an image and what a person feels doesn't always line up, and that is well documented in the research. What I have not found is anyone testing the third thing. Nobody is putting joint mobility next to the image and then next to the pain and then asking why all three things tell a different story, okay? So that is what's confusing in society. It's almost like three people are telling you three different things, and we're totally telling you three different things. And when someone asks me which one is right, guys, my honest answer is that I do not know, and I think the question might be wrong, okay? All of us are right in what we see, okay? So let me just kind of fast forward. So this person went to see her surgeon. She is bone on bone, okay? When she went back, he told her, when her knee was bone on bone, that there was nothing else he could do for her. He made that statement. She said expressly, my surgeon told me there was nothing else that he could do for me. Okay? And I want you to look at what he said there. That is the statement I want to look at here. Okay? He looked at an image. He described what he saw. It was bone on bone. And when a surgeon says there is nothing else I can do for you, what he is saying, there is nothing else non-surgical I can send you out to. But that's not what most people hear. And what she heard was that there was nothing else that could be done. Not nothing else non-surgical, nothing else at all. And the moment she heard that, then she made that decision. She felt like there's no hope for her knee, and surgery was the only option for her. And I want to separate these things, okay? Because these things are where people get really confused, because in the moment you want to make the right decision, but truly you're being faced with a surgeon that's saying, there's nothing else I can do for you. And he's standing there looking at you and you're going, well, I guess I have to have surgery. So if any of you guys have had that, I do want to know. I want you to put that in the comments, okay? Because there are people who go, no way, and walk out of there. And then there are people who go, let's schedule it. Okay, so there is three different things here. One thing on the image, one thing in how the client feels, and then one thing that I felt, which was no structural feeling in there, which we know, I mean, there's just testing, all of that. They've already proven in the research that a feeling, like when we do joint testing, is really, I don't think we can establish that, okay, because it's not a finding on an x-ray. Those are all related, but they're not the same conversation. Here's what I mean. I'm using her own timeline as a path. She was asymptomatic for about a year. She was seeing me twice a month. She was training twice a week. Her knee pain had gone away, and she was starting to wear a barefoot shoe. and then she stopped doing her training. Okay, took 3 weeks off from training, and her pain increased, and then it got worse. Now, nothing structural changed in that knee in 3 weeks. I want to be very clear about that, because I am not telling you that in 3 weeks off caused bone on bone for her, because it did not. That change had been happening for years. We already know that her hips were restricted, and we were working to unlock those hips and get the muscles that were inhibited back working. And she was also working on the larger muscles. And in the 70s, she sort of, if you look at this case, what would happen if she was that lady in her 30s, right? And she had started in her 30s, what would happen? We don't really have that answer. But this lady does have structure, okay, which tells me that the pain and the structure are not locked to each other the way maybe she's led to believe, okay? And I want to be careful here, because that's the part that some people are going to get angry with, okay? I'm not saying that she does not need surgery, guys. I have no idea, and I am not the one who decides whether or not somebody needs surgery. I don't diagnose it. I don't treat it. And I do not give advice to anybody on whether they need to have an operation or not. It's not my lane, okay? That's between her surgeon and her. And I wouldn't go there. What I am saying is I want you to look deeper here, because this is what I feel like matters. A structural finding is not a verdict on how you're going to feel and how you are going to move. Surgery is an option. It's not the last option. And it's not the same thing as the last option. And here's what I want you to hear here. She has 9 other major joints in her body, okay? She has muscles that she can still build. She has a whole movement system that is going to have to carry her through a surgery, through recovery, and through the next 20 years of life. Here's the problem. If we've already seen her for 10 years, and we know that she has gotten care 2 times a week, weekly, decreased it to twice a month, and did her training, when she goes in to have surgery and nobody is watching all of those other joints, nobody's testing it, all we're doing is going in for a surgical repair at the knee. It's interesting to see what is going to happen to that, because we already have research that supports that typically when you have a surgery, then within, I can't remember what the amount of time is, you're going to have another surgery. So I'm just hopeful that that's not going to happen to her. She's going to bounce back. She's going to do better. We're going to work on the knee, and she's not going to advance with any more structure. And then she'll come back and finish, 2 times a month, keep opening those hips up, keep them as safe as we can. And then, she can do her training. But that's what I'm hoping for, okay? But here's the question I would ask if I was the person at the surgeon's office. And I'm not the one to answer whether she needs that surgery, okay? Her surgeon and her. But instead of wondering out loud, here's the question I would ask if I were sitting in her chair. I would say, I've been seeing a stretch mobility coach, and I've been going for 10 years consistently. I've also been training 2 times a week. And after I see the stretch mobility coach and she opens up that motion and then turns back on those muscles, I have no pain. I know what my imaging shows. I know what you typically do, which is surgery. But if this is going to give me pain relief, is it reasonable that I could delay my surgery and avoid it? And this is the whole question that I want you to ask when you're sitting in that surgeon's office. It'd be really interesting if you start doing this. I'm saying this because it opens up the potential to him now saying, yeah, you can totally wait. Or him saying, no, if you wait, there's going to be a bigger problem, okay? So you can't get any of that if you don't ask. And most people never ask that because, when you hear a surgeon tell you there is nothing else I can do, he is a surgeon. He's just saying there's nothing else non-surgical that I can send you to. You went to PT, you got an injection. Those are the treatments that people typically have when they have pain. Okay, so let's talk about the research, what it says, the research says about that particular question. Okay, so there is a randomized trial on exactly this. 100 people with moderate to severe knee osteoarthritis, and that's what she has. Every one of them had already been found eligible for a knee replacement by an orthopedic surgeon. Half of them got the replacement. Half of them got 12 weeks of non surgical treatment instead. That treatment was supervised exercise, education, dietary advice, insoles, and pain medication. Here's what it found, okay? And some of this doesn't support my argument, okay? Because I want to share it all. Surgery worked better. The people who had the replacement improved more on pain, okay? We're talking about pain and function when we're talking about the knee at 12 months than the people who didn't, okay? And that's not a small difference, and I'm not going to speculate that it is. Here's the other finding from that same trial, though. Of the people who were told they were eligible for a knee replacement and they didn't get one, 74% had still not had surgery 1 year later. And the same group followed them for 2 years. And at 2 years, 2 out of 3 people who had been found eligible for a replacement, after 2 years, still delayed it. Now, I want you to sit with that because these were not borderline cases. A surgeon looked at each of these people and he said, you qualify for this operation. There's nothing else non-surgical I can do for you. And most of them went 2 years without the surgery. So when a person is told they are eligible for a knee replacement, what that sentence actually means is that they qualify for the replacement. It means that the insurance is going to cover this procedure and it's okay to have it now. It does not mean your clock has ran out. Now, here's the finding. I want to talk about this finding a little bit. That same research group asked 9 orthopedic surgeons what matters most when they decide someone is ready for that knee replacement. And the surgeons said imaging, severity, pain, functional limitation, and whether the person had failed non-surgical treatment first. Those are the criteria, okay? And then they looked at 200 actual patients to see what the decisions were really tracking. Image severity, functional limitation, those were in there. But whether the person had responded to non-surgical treatment was not associated with the decision at all. The authors wrote that it was not included in the decision making. So the thing that the surgeon said mattered was not the thing that showed up in the decisions. Guys, I'm not calling anybody out here. It's a hard decision to make in a short appointment. Your knee hurts. You just want the knee pain to go away. You think you've done everything that you can. But it does tell us that the question of whether non-surgical care is working for you may simply not get asked unless you ask it, which brings me back to this client, okay? Here's what her 2 weeks looked like. She had pain. She saw an orthopedic doctor. She had an x-ray. Within 2 weeks, she went to 1 physical therapy session. She had an injection and she scheduled surgery. That was all in 2 weeks. 2 weeks. Now, I want to be careful about what I'm saying and what I'm not saying. I was not in those appointments. I don't know what she told him. I don't know how severe her pain is, how it's limiting her, and what she wanted. And it's entirely possible she walked in and asked for the surgery herself. Okay, I'm not telling anyone anything different here. What I am saying, okay, is that 1 physical therapy session is not a trial of non-surgical care. It is 1 session. Nobody found out whether non-surgical care was going to work for her because nothing ran long enough to find out. And she had something to report. She had changes when I worked with her, and she never put that in front of her surgeon. And I have to be honest with you about what that research is and what it is not. The research above that I talked about, that 12-week program, it was not a stretch mobility coaching program. Nobody has studied what I do against the knee replacement. I'm not going to sit here and let you believe that they have. It was 100 people in Denmark, and surgery still came out ahead on pain and function. So I'm not telling you these studies say skip your surgery, okay? They do not say that. What they say is narrower, and it is enough. Eligibility does not mean you have to do it now. Most people who qualify do not go immediately into a surgery. So then the question of whether something non-surgical is working for you may not come up unless you pose that question. I'm encouraging you to pose that question. Okay, I'd love to hear those answers. And here's what I've seen and what I cannot claim. There is one more study I want to give you because it's the closest thing I found to somebody testing my question. In 2000, researchers at a military medical center took 83 people with knee osteoarthritis and randomized them. Half got manual therapy plus supervised exercise program, and the other half got sub-therapeutic ultrasound that really wasn't doing anything. They got that twice a week for 4 weeks. Now, they described the treatment as manual therapy applied to the knee as well as the lumbar spine, the hip, and the ankle. Okay? The hip, the ankle, the low back, treated as the person needed it and not just the hurt knee itself. Okay? And at 8 weeks, the treated group had improved their 6-minute walk distance by 13%, and their symptom scores had improved by 56%. At 1 year, they still had those gains. And then this, at 1 year, 20% of the placebo group, the ones that didn't get any actual hands-on, had undergone a knee replacement. 5% of the treated group that got the hip, the knee, the ankle, the exercise, the taping, the manual therapy, all of that stuff, 5% of those people went ahead and had a knee replacement. And so the authors concluded that manual physical therapy combined with supervised exercise yields functional benefits and may delay or prevent the need for surgical intervention. So I have to say that. Now let me hold myself to the same standard I have been holding everything else to. Those surgery numbers are small. 20% of 41 people is about 8 of them. 5% of 42 is 2, okay? That is a real different, and it's really small, and I wouldn't want to build business on 8 people and 2 people, okay? It was 4 weeks. It was not a long length of time like 10 years. Like I say, like from a 30-year-old to a 50-year-old, we got 20 years there. It was manual therapy. It was exercise, which is not stretch mobility coaching and not my testing, because I do not do what physical therapy does, and physical therapy doesn't do what I do. So it does not prove my model. Okay, nothing does. We haven't had that type of study out there. Okay, here's my problem. That study is from 2000, 26 years ago. A good journal, it got a positive result, and somebody went above and below the joint that hurt and got a quarter as many knee replacements at a year. Okay, so I've been telling you all episode that nobody is tracking these restrictions, and we're on a predictable movement decline path, okay? But this research here, somebody did look and they found something. As far as I can tell, nobody built the next study on top of that. And it'll be interesting to see if they can really get out there and do research on people for a longer period of time. I think that would be really cool. It would actually tell us more. And I'd love to have, maybe some people taking physical therapy, some taking chiropractic. This would be a dream, I know, a pipe dream. And some people doing stretch mobility coaching. That would be pretty cool. I've worked with people who were told that they were candidates for knee replacement and who have not had one. And when I test them, the joint has motion and it's stable, and they keep coming back and they keep loading it, and the surgery hasn't happened yet. I've also had one younger person that came to unlock her knee, but she had such severe knee instability that surgery was her only option. Now, here's what I can't tell you, okay? I do not have a version of that person who did not come see me, so I don't have anything to compare my people to. And I can't tell you the surgery is avoided because I don't know what happens in 10 years, and I know what I know is that the people that I am seeing are not going into surgery, and I'm the person watching a very small number of people in one studio, and that is definitely not evidence. That is a pattern, though, and I keep noticing the same pattern over and over and over. So it is worth studying, and it is now for you to decide what you want to do. And this leaves me with a question, and I think it's the question that we all need to ask. When we're looking at this research, the trial ran for 12 weeks. It followed people for 2 years. The 12 weeks was exercise and education and diet advice, insoles, and pain medication. Guys, it's good general care, right? Nobody in that study tested the joint. They didn't restore accessory motion in the entire that I know of. They did physical therapy, and I know what physical therapy's done because I worked in it for 25 years. Nobody asked whether the knee was stable before they loaded it, okay? So the question I keep coming back to is what happens over 10 years, over 20 years, not 12 weeks of general care? What happens when you work on all 5 drivers and you are supported the whole way? What happens if you do continue with the frequency and we keep that accessory motion as open as available as we can? What happens if we get those muscles that are inhibited and turn them back on, open the pathways, we rebuild these larger muscles, and now you can actually move better without compensation? What happens if the nervous system is not stuck in a protective pattern and that is kept up year after year? The way you would keep up anything else that you intended to keep until you were 70, 80, and 90. If a knee is stable and it stays stable, does the timeline change? Can a replacement be put off and put off long enough that it doesn't need to happen? Guys, that's the question I do not know. And I want to be very clear about why I do not know. It is not that the answer came back as a no. It's that nobody has run any study at this length that I am seeing in here. 12 weeks is not 20 years. And general exercise and general manual therapy is not a tested and restored joint. So the study that would answer my question hasn't been done, which means I cannot promise you anything here, and I wouldn't want to. What I can tell you is the question is open, and I think it's worth someone opening it. So here's what is not my lane, guys. I do not do any acute injuries, okay? That is healthcare. Go to your doctor. If you hurt yourself, go to your doctor. Better yet, seek out a private PT. They are going to be really good at helping you. If you found this information helpful, I help people that want to move well in their last half of life. Those people that see the predictable movement decline path and want to be on a healthy movement path. If that's you, I would love to connect and help you stay on course. Thanks for joining me today, guys. And if you felt like this information was helpful, then please share this information with your friends and your family. I would love to help you or your family. Thanks so much for joining me again, and I will see you next week.